All right, let's go ahead and get started. Welcome to today's webinar on quality of life plans for children with disabilities. This webinar is hosted by Medical and Life Care Consulting Services, a case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is 𝐏𝐥𝐬𝐿, and I'm the moderator for today's webinar. This webinar is anticipated to run approximately 50 minutes with additional time provided for questions and answers. Participant audio will be on mute throughout the duration of the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. After the webinar, we'll send an email with a link to a short survey and access to an on-demand playback of the webinar. Again, we are excited to host today's webinar and do look forward to an opportunity to work with you. Let's go ahead and get started by presenting today's speaker, Cynthia Bourbeau. Cynthia Bourbeau is president and founder of Medical and Life Care Consulting Services, often referred to as MLCC, and has worked as a Massachusetts registered nurse, certified rehabilitation nurse, certified nurse case manager, and certified nurse life care planner for over 3 decades. Founded in 2001, MLCC provides life care planning services, Medicare set-asides, legal nurse consulting, and much more throughout the United States and internationally. MLCC also provides case management services throughout the Northeast region of the United States and a wide range of care consultation for catastrophic injuries and for families with children or individuals with disabilities. Cynthia is a member of the Association of Rehabilitation Nurses, the American Association of Nurse Life Care Planners, the International Association of Rehab Partners, and the Case Management Society of America. She is also a board member of the Certified Nurse Life Care Planner Certification Board. At this time, we're going to pass it to Cindy.
Great. Thank you all for taking time out of your busy day to join us today. We're going to be discussing a subject that I really enjoy. So why don't we get started? The agenda is, what is a quality of life plan? Who requests it and uses quality of life plans, and why are they important? What is the purpose or objective of the plan? Key components of the plan and how they're prepared will be reviewed. And then strategies for effective communication and collaboration with professionals and support networks. So what is a quality of life plan? It's a special needs forecast and care management plan for individuals, families, or fiduciaries requiring long-term care and care management for individuals with special needs. And it can be individuals of any age group. And so where does it fit in? There are so many different types of things that we do these days. We do as nurse life care planners or life care planners. We do life care plans, we do opinions, we do projections, we do so many different things. But you can't talk about quality of life plans without discussing who and what we are as nurse case managers, healthcare professionals, and certified nurse life care planners. As nurses or healthcare providers, we have met patients in all seasons of their lives, right? And assisted them with attaining goals of improvement in their health status for maximum medical improvement and quality of life. That's always the #1 goal. That's what we all want out of life, right? When we're not able to get patients to the pre-injury status, we then assist them in adjusting to the disability and outlining a comprehensive life care plan, whether this be in the legal arena or directly with patients and their families. So I've been in business for 22 years this year, and I take great pride in the fact that we provide the same caring experience for all our clients, whether they be children or adults, whether we're providing services through medical legal services or direct care management to our patients. It's why I think that we as healthcare professionals following patients through the continuum of care are so effective in outlining appropriate care for the future. We continue to work with people to help them face the challenges that life throws at them. And I think it gives us a unique perspective based on the reality of day-to-day living with these patients and helping them get through their days. So who do we serve? Today we're speaking specifically about quality of life plans, more for special needs children, but referrals can be received from the patients themselves. I've gotten calls from burn patients that are aging with contracture and decreased mobility issues, or we can get calls from families with disabilities, so children with autism, cerebral palsy, serious respiratory conditions, it could be anything, and the elderly, or insurance companies. We get referrals from plaintiff and defense attorneys, and I think that if we went through it specifically, step by step, who requests the quality of life care plan? If you would switch to the next slide, CG. I think once you give birth to a child, I think you never stop worrying about them, right? With patients with special needs, there's that additional worry about what will happen when your impaired child, to your impaired child when you age or if you have an accident or become ill. Most of us consider the issue of care of our children in the event of accident or death, and often identify who will care for them in our wills. I can remember doing that when I was younger, and I had willed my children to family members, and that stayed in place till they were like 30. But this is an extension of that kind of planning. How will they keep their family members healthy and happy with the best possible life if they are no longer there? So second is patients request it, right? Just like I talked about that burn patient. They'll call and request a focus report about what is available regarding living options as they age, or if they have a specific health issue, how are they going to handle it? Or sometimes it's a family member who's faced with someone with memory issues. All types of scenarios can occur. Trust managers or fiduciaries who are managing trusts also make referrals often. And family law and divorce attorneys. So in regards to trust managers or fiduciaries, when there are birth injuries or accidents that occur to both adults and children, there are often trusts that are set up for that patient's care. And surprisingly, if there's a life care plan when the injury is in litigation, that doesn't get sent to the trust manager. So usually they're working blindly, and so details regarding what is appropriate or should be utilized through the trust can arise, and either a quality of life plan can be requested to find out what is covered by insurance or what is covered by the Department of Disability Services versus what needs to be paid by the trust can occur. Oftentimes I'm called back when it gets into the trust situation to answer questions or facilitate something that they need. If the family now is looking for a home that's accessible, evaluating options that are available for them, and then what would have to be done to the home to make it appropriately modified. In regards to family law attorneys, unfortunately, life is stressful for all of us. So there's a multitude of reasons that discord can happen in a family, but unfortunately having a child with disabilities or an aging parent who has care issues adds an added stress to marriages. And so I've been asked to provide quality of life plans in that setting also. So for example, in the event of a divorce, to identify what each parent needs to put aside for that care for that child in the future. And family law attorneys are always also assisting with elderly clients, looking for ways for them to stay in their home. And so when I've been approached about from from family law attorneys also. So the purpose and objective of the plan. First is to outline long-term care based upon the individual and family's wishes. And in that, we forecast care and cost estimates, do cost estimates, and establish a plan for providing the care management. So there's all different kinds of services that you can offer when you're doing this. It can be quality of life projections, which is a more modified plan with third-party benefit analysis in it. So outlining some sources, collateral sources for payment for some of these things. Or a comprehensive life care plan with third-party benefit analysis, which seems to be the most popular that I'm asked to do. Sometimes this evolves into task management. So as I talked about the family that needed to find a specific home for their child to be brought up safely, or it could be for assistance with DME, and oftentimes it's to set up home care and support care for that child. Limited care management could be ongoing case management that you would do for that child, and it could be for a focused issue, so to resolve a specific problem. And oftentimes, again, it can be ongoing management of a care team in the home to make sure that it's working smoothly, that there's no problems, that everyone's trained appropriately, and the patient's needs are met. And then it could be total care management, which is everything. So that can be arranging home care, providing supplies, ordering supplies in DME, and making sure that that patient has everything they need medication-wise, organizing doctor's appointments, attending doctor's appointments. And so all of those types of services are things that you see in this arena and in conjunction with a quality of life plan. So what is the process for the special needs quality of life plan? So first of all, the referral is received, and I've listed all the types of referrals that where we could get it from. And a conference call is held with the family to determine what the diagnosis and needs are. So what are they looking for, and what do they hope to achieve with this report? And this phone call will identify what areas they want you to focus on. It can be just placement in a facility or home care status for the future, or it can be everything they will need for health and maximum quality of life. And it always amazes me that, people don't know what they don't know. So your expertise really helps with providing the information that they need to keep their family member healthy. And we sign a contract with the specifics of the assignment. And then a request for all pertinent medical records for review is done, as well as early intervention records, IEP records, and any benefits that the child is presently getting. Once medical records are reviewed and summarized, then an in-person or remote meeting is held with the child and family. I mean, this has been the time of remote visits, so everybody's doing Zoom like we're doing today. I personally prefer in-person meetings if everyone is agreeable. This is a very in-depth personal discussion that you're having with these people regarding medical issues. But also discussing all the patient is presently using for resources and equipment. Insurances are discussed and any benefits or assistance that the patient receives now, whether they already have Medicaid, whether they are on a waiver program, whatever kind of insurance they have. The family resources are reviewed as well, because obviously if they have, significant bills that they have to, and issues that they have to address, it affects the family benefits. And the goals for future care are reviewed and identified so that you're really providing them just what they need, not just a cookie cutter report, but specifically what they're looking for. And then depending on the level of the project, I will also contact treating physicians to get updates and answer questions and get questions answered. Oftentimes, I'm asking for recommendations regarding treatments or to solve a specific problem that the patient or the family are having. And this comes apparent in the evaluation. So recommendations can be made in the report for follow-up by the family regarding treatment with their physician. And we always outline these questions. And I've been included in appointments where I'll go with them and obviously give them the questions ahead of time. But if the information that we need is not forthcoming, then find different ways to ask for that information. A report is generated which covers much of what a life care planner would cover. Again, the details of the report depend on what the family has requested. I try to be sensitive to the cost to these families, and I'm very clear about the time that it may take to complete a project. Sometimes the requests are just focused tasks that need answering, and I research it and define it in the report. I think that's something to do with the nurse in me. I have trouble charging patients for anything. So it's a skill we all have to learn when we're doing these types of reports. So what is the process for the special needs quality of life forecast? Whoops, I guess I got an extra page here. Sorry about that. So special needs forecast. So this is a development of a treatment plan to promote the restoration and then maintenance of health. It looks at the entire child, not just a disease or injury, but its effects on all body systems and all aspects of his or her life. As a nurse, we use the nursing process to formulate a plan of care to identify the patient's individual needs. Assessment, diagnosis, implementing, and then evaluating. My background is rehabilitation nursing, and so I believe it's important to achieve maximum medical improvement, whatever level that is. So I never assume that patients have reached maximum medical improvement until I've seen how they've been challenged and what they've accomplished with that challenge. So understanding the patient and medical treatments to date. So with a pediatric life care plan, we review all the medical records from birth onward. In this instance, as it's not for a legal system or trial, I would not need to review all medical records. However, I do think that at least 2 to 3 years of medical records would be beneficial to identify and accurately present future treatment needs. And some families keep really great copies of their records and are able to give you this. Some parents are right on top of their care and others are not. So each of the situations could be reviewed individually to determine how far back medical records would be needed. Records should also include early intervention or IEP records and any other important information identified in the initial interview. Included in this evaluation is the household income and what the patient receives in monetary benefits monthly. Current household expenses are also itemized per month or year. Any debts of the guardian, parent, conservator, decision maker, / whatever, should be taken into consideration and see what's possible for that child's future. A successor guardian should be identified who will assume responsibility of the child if the parent is no longer able. Clients should have a living will in place. If not in place, then one should be set up with a copy sent to the primary care physician and hospital of choice. Oftentimes, prepaid funeral contracts and burial plots are set up for the patient prior to anyone's sudden illness or death. Obviously, this is a very difficult conversation to have with families with young children. Oftentimes, that doesn't happen at the initial visit, but will happen as you work with them and get to know them a little bit more. I think when you have elderly clients that you're working with, it's easier to have those conversations because they are all thinking the same thing. And the realities of life, they know what they are. So they're oftentimes prepared in that way already. A life care plan includes chronological review of records to include, but isn't limited to, medical records from birth, from the date of injury, and at least 2 years prior to injury. Again, school records to include early intervention or IEP, records and billing from all vendors regarding supplies and services, any depositions, expert witness reports, or anything that are available that have to do with this child's injury or illness. And the data collected covers all areas of their life. So it includes physical, psychological, cognitive, functional, developmental, socio-cultural, spiritual, economic, and or lifestyle information about the client and his or her family. So uncovering present status, all aspects of the patient's life is reviewed. So if you're a life care planner listening to this, these are all things that we are looking at all the time in regards to our life care plans already. It includes each body system function and how the injury or illness affected the patient's system in life. This area of the life care plan, especially for children, should reflect their status prior to the injury, how it affected their developmental status, and where they are at present. I'm really careful to include all the changes and evolution of their development as I do this. An example of this could be like vision status. If you have a child that was born healthy and has had no real medical problems and then went in to have a procedure and came out with injuries such as brain hemorrhage and hemiplegia, this could affect the patient's cognitive abilities, communication skills, gross motor and fine motor function. Pre-injury, when discussing vision, the patient could have had full normal vision 20/20 to both eyes. Post-injury, the patient's cognition was impaired and he was manifesting problems of intellectual disability. Testing could show that his vision was good, but he had weakened eye muscles that resulted in nystagmus, diplopia, double vision, or strabismus. All of these things can lead to impaired perception of the child's environment. It's difficult to ascertain what the patient is actually seeing and absorbing, as he could also have cortical visual impairment. And this is a decreased visual response to neurological problems affecting the visual part of the brain. All of these diagnoses are important to take into account when you're determining the patient's future needs. So you can see household income, all the things that I've been listing are on that slide. Incorporating present and future medical, educational, and vocational recommendations. And these, again, are all the areas that we review in life care planning. So when you're dealing with an adult, the adult post-injury is going to be where they are. But with a child, or if they aren't where they're going to be within the next year and a half or 2 years, they're going to be where they are. But with a child, there's no way to know with 100% predictability when you are seeing a child early in their development and when they're young. You can predict how they have met their developmental milestones to this point, but if a child is very young, there are all kinds of scenarios that can occur. During the growth and development years, I feel it's important to facilitate maximum medical improvement possible so that the patient reaches their best self in life. So all of these areas of treatment, things that we would put in place. In addition, treatment varies with different ages of development, and that plan should reflect the changes that would be needed during different years. So medications, obviously the patient that is 5 years old is not going to have the same medications as an adult, but I use a variety of medications that they are on as a child as a basis for what they would need as an adult. And if they have surgery scheduled, they'll need pain medications post-op or other medications. If they're on anti-seizure medications and their seizures have been continuing, well, obviously they're going to be on medication when they're older. In regards to home care services, these change as patients age. A 4-year-old can be managed by parents for the most part with manual lifting. However, by the time they're 8 or 9 years old, they're getting too big to carry, and so lifting equipment will need to be added. In regards to facility care, you have to consider what is happening to the parents as the child grows. How old are the parents? Were they 20 years old when they had their child? And so are fairly young as the child ages, or were they in their 40s and almost 50s when they had their child? At what age does it get to be too much to do things manually for an adult-sized child in the home? What will you do if the parents are no longer available to care for their child due to illness or death? And all these things need to be taken into account for the quality of life plan. And I think the more pediatric life care plans that you do, these quality of life care plans become second nature because they're so intertwined. In regards to transportation, a child at 5 that has mild CP may be able to be a functional ambulator for short distances. Their impairments may be primarily their lower extremities so that they could have hand controls for their car and be able to drive when they age. However, if a child's mobility is in a wheelchair, you want that child to be able to be with that family everywhere they go. Even a child with moderate CP that can ambulate with assistance to the bathroom may not be able to get in and out of a car consistently and may need a van for transportation because they can't walk long distances. If a family is unable to care for a child at home and they need to be in a residential home, the residential home can transport to activities, but how does this family still be able to get this child home so that they can spend time with them at family events? A van may still be necessary. You have to get to know the families and the patient as well as you can to prepare for every eventuality. And it's really a work in progress. Architectural modifications are also necessary for most families with disabled children. And it always amazes me how people adapt and compensate for what they don't have. Modifications can be ramped to full house renovations if the child has the ability to live independently in the future. There's a whole host of options. So talking about orthotics and prosthetics, these are usually very clear-cut on what a child needs. Children grow and need constant adjustment and fabrication of appropriate supports. And I think that this is one of the greatest barriers for the parents because these children are growing and oftentimes I see children who have grown out of their equipment and never received the next available size. And that can be because of problems with arranging evaluations to be able to get the proper equipment ordered, or it could be not even being aware that there are, how frequently they should be changed. So a big part of the job here is education. So when they don't have that appropriate sized orthotic or prosthetic, it impairs their functional status each time this happens because it sets them back mobility-wise, functioning. Frequent types of orthotics and prosthetics, there's a lot of them. AFOs, KAFOs, Benic vests, and other kinds of various trunk supports. Prosthetics, resting hand splints, flexion splints for the hands, immobilizers, air casts for tone and spasm, Medipotis boots, custom shoes or custom orthotic inserts, and a variety of splits and braces. And really the list goes on and on and on. And they're coming out with new stuff all the time. And families also modify things to make it work. Surgical and medical procedures depend on the patient's diagnosis. So it also depends on their previous surgeries and potential maintenance surgeries. Examples of this could be hydrocephalus with shunt placement, would be replacement of the shunt every so many years. Baclofen pump revisions, G-tube revisions, suprapubic catheter insertions later in life, colostomies, putting them in, and also reversals, debridement of wounds, rhizotomies, lysis of nerves, contracture releases. The list is, again, non-ending. So you should identify which procedures are reflected in the present treatment plan and which may be identified by the treating physician as possible or probable treatment in the future. Examples of that could be a child who has dysplasia of his hips, non-weight bearing, very slow to be standing. He may need osteotomies of bilateral hips, or oftentimes I get calls from people who have paraplegia and they've torn their rotator cuff, and they use their arms obviously for all mobility and functional status and all weight bearing. And so having to have rotator cuff surgery for someone who's a paraplegic is definitely life altering and very stressful because they're really non-weight bearing on that limb for a good 6 months, if not longer. that's 6 months is if everything goes perfectly and they're strong young people. But that's not always the scenario. So it can result in needing 24-hour care for a significant period of time because they can't get themselves in and out of bed or to work, to get into their chair or whatever they need. So incorporating present and future medical, education, and vocational recommendations. So education needs are really well identified through the patient's IEP, neuropsych evaluations from communication specialists, such as those from Perkins School for the Blind and school programs. All that occurs in school needs to be carried over into everyday life at home. So whatever treatment the child gets at home, that should be carried over to the school program, and the same vice versa should happen. Examples of that would be there's patients who do absolutely wonderful toilet training at school and don't have any episodes of incontinence, but when they get home, they're tired, they don't want to do it, and so that program that they have at school, they don't have the same confidence. And that can be from a variety of reasons. Oftentimes when you have home care in the home, if there's new home care aides that are coming in, those are all reasons why there can be a regression in progress. So federal programs mandate that children are given what they need in school to be able to participate in school, and all children are entitled to this. This could include speech, PT, physical therapy, occupational therapy, assistive technologies, neurology or neuropsych evaluations, nursing services, one-on-one paraprofessionals, vision teachers, teachers for the hearing impaired, the list goes on. And oftentimes to prevent loss of skills during the summer, they are approved for a summer program, so their services are extended for another 4 or 5 weeks in the summer. All these services are specifically so the child can participate and benefit from the school program and participate in school. That's really the focus of it, although a lot of what they do, schools are great, and a lot of them have life skill tracks so that children with some disabilities are able to work towards being more independent at the school. In addition to this, additional therapy, however, is needed in the outpatient or home setting to focus on maximizing that child's development. I feel there's this window of opportunity when children are little for them to reach new goals, and you don't want to miss those opportunities. If the child goes home and never does the things that are needed to further develop, they won't develop. And also children with behavior issues due to autism or intellectual impairment may need behavior therapists, and these are done in the school setting, but also can be set up through the school in the home setting, so the patient can actually do and follow the same behavioral plans that they have in school. So it's also educating the parents along with the student. So identifying future care options. So I think where this, even though we have goals in behind every life care plan we do, everything that we put in place is for a goal. We specifically put long and short-term goals in place with quality of life plans, because really you want it to be specific to what this family is hiring you to do. So it could be a short-term goal, could be the family will receive in-home instructions regarding behavior issues for an individual with autism. So evaluation by a BCBA would be completed, a board-certified behavior analyst, to achieve improved behavior management. They would put a plan in place, and then they would have a technician that can come out to the home on a regular basis, whether it be twice a week or 5 times a week, to get a patient's behaviors back in control. Or another example could be deterioration in gait will be evaluated by physical therapists and even a physiatrist, and a treatment plan put in place by a specific date. And then long-term goals are what's going to happen when I am not around or if I'm ill. So identifying and giving them peace of mind about a residential home or whatever type of service they're looking for, but a residential home within 50 miles of their home for management of future care needs, and identifying the Department of Developmental Services approved day programs for that child to go to. So Plan 1 could be living at home with family caregivers for the lifetime. Plan 2 can be living at home with family caregivers until a defined age, and then maybe going into assisted living or some other type of service. Or Plan 3 would be a residential home because maybe their medical condition has deteriorated and they cannot get the care they need for their family member in the home. And even though that's not a wish of any family member, sometimes just having that information about what is possible in the future gives them some peace of mind. And also how much it's going to cost and what can they afford and who pays for what and what's out there. So I just had a couple of pages of life care plan, a quality of life plan, life care plan, right? So you can see here, those of you who are familiar with life care plan shows there's a column for item, service, the ages it's going to occur during, why you're recommending this, how many times it's going to happen, and what the costs are, the base cost, the annual cost, and the lifetime cost. And then resources, where the cost came from, and then payer sources. So is this covered in the school program? What happens when they're when they're older and they're out of school? Who can provide that service then? And so those are the kinds of information that we give in a quality of life plan. With assistive technology, it may be through the Department of Developmental Services. It could be through a health insurance where they are seeing a speech therapist who has assistive technology experience and licensing. And, you know, it's really hard because I do these plans all over the country, and some areas do not have a lot of services. So families have to wait months and months in some of those rural areas because there aren't a lot of providers that are aware of, for example, how to use a Dynavox and how to train a family to use a Dynavox for communication. I've actually had families tell me that they Google things on YouTube to learn how to use equipment and how to learn how to lift their family member with you know, like a Hoyer lift, because there was no one in their area that could train them, which seems hard to believe in this day and age, but it does happen. So this is just a sample of that. With impaired patients, there may be different options or scenarios about potential needs due to loss of family or inability for the patient to care for the patient in their home. And so I often put 1 to 3 options. These tables demonstrate the examples of therapy options throughout a patient's life. With this patient in this pediatric life care plan, the child needs 2 separate hip surgeries, and it's anticipated that it'll be done in the next few years, but it could be done as late as age 21. And so OT is provided in the home post-op, and you can see that on this table. You want to make sure that you've outlined everything you think this child's going to need, because these families are going to follow this like a plan. If you could just switch down to the next pages, these just show additional, there we go. So we take into consideration what the school offers, what they should get in addition to that after school. A lot of families don't even realize that, you know, they get these services at school and they think that's all there is. But obviously through health insurance and with specific needs, that because whatever it is life-threatening, additional services are available, and it can be through insurance, it can be through the Department of Developmental Services, depending on what the issue is and why the child is sick or ill. So if you could go to the next page and just go ahead and think that's the last page of those. So obviously my background is rehabilitation, so my focus is always to make sure that the plan is focused on maintaining health, maximum functional status, and independence and prevention of complications. We want to keep people out of the hospital so that they can live a healthy life and enjoy being with their family. We don't want them to be just spending their entire life trying to be 100% again. You want to get them to maximum medical improvement and then focus on the things that make them happy and make their family happy so that they can all enjoy life together, right? And I feel like I've got multiple hats when I'm talking here. So I'm talking life care plans, I'm talking quality of life plans, and I'm talking being a nurse and case manager. So let's talk about benefits. We've talked about how to evaluate and present the variations of quality of life plans. So now let's talk about payer sources. And most children with diagnoses requiring planning for the future are on Medicaid, usually already by the time I see them. When you begin your evaluation, you'll need to find out what the current benefits that that patient has. Now, that may not be true in all areas of the country. I've done multiple plans throughout the country. Most hospitals have services that when people are ill or have chronic problems, they set them up with the appropriate services, but you can't take that for granted and assume that. When you begin your evaluation, you find out what the current benefits that they have. So it's just amazing to me, although a lot of them have Medicaid and a lot of these benefits in place, often they haven't gone down the weeds and even know about all the benefits that are available out there. And really, every state has got to look at what's available in that state. So there is a lot of research that goes into this. So federal and state programs. So the department, so before we switch, I'm sorry, let's talk about, so the benefits can be, if you could go back, Gigi, I'm sorry, I'm talking off cuff and I shouldn't do that. So the benefits include federal programs, state programs. You consider health insurance plans, sometimes private pay, a lot of times private pay, dental insurance, vision insurance, mental health services that the parents may have, Division of Vocational Rehabilitation has services, there is SNAP and Section 8. So obviously every program in every state is going to be called something different. So you really have to look up what specifically each state provides. And so we're going to primarily talk about Massachusetts here. So federal and state programs, you've got DDS, the Department of Developmental Services and Youth, serves children and youth between the ages of 0 to 22. In order to receive services from DDS, the child's parent or legal guardian must live in Massachusetts. These are Massachusetts information. Emancipated youth can also apply for services. There are different eligibility requirements depending on the age of the child. For children between the ages of 0 to 4, the child must have a serious developmental delay or a condition that will cause a developmental disability. So if the child does not receive service, so in other words, if their problem can result in a developmental disability, if they don't receive services, then they qualify. And examples of these kinds of conditions could be Fragile X syndrome or Rett syndrome. For children and youth between the ages of 5 and 22, DDS requires that the child have a severe chronic disability due to one of a certain number of conditions, and that includes intellectual disability, autism spectrum disorder, Smith-Magenis syndrome, Prader-Willi syndrome. DDS also serves children and youth that have an intellectual disability or other conditions that result in substantial functional limitations. This means that the child has difficulty with certain everyday activities such as learning, mobility, expressing themselves with language, understanding language, and taking care of themselves. Some of these conditions that would meet this criteria would be Williams syndrome, Down syndrome, cerebral palsy, spinal bifida, fetal alcohol syndrome, Fragile X syndrome. Every state has free resources, family support services. So there are some of them in Massachusetts are intensive. It's called IFFS, and it's Intensive Flexible Family Supports. And this is help for families caring for the child with disability in the home. It provides case management services and funding to help families purchase services or items. The second service is a medically complex program. This is for children with serious cognitive, physical, and/or complex healthcare needs. Case management and funding is provided for services up to the age of 25. And the third one is called Planned Facility-Based Respite Program for Children, which is self-explanatory. There are also community residential education programs, and this is a program that exists between the school departments and DDS to provide additional supports to children and young adults to prevent them from being placed in a more restricted educational or out-of-home placement. So DDS works with the schools in this, and it's really turned into this huge program, which is great. There are also additional resources in each state. And so if you go, I went on multiple sites for different states. You're able to go on there. They give you all of the links to all the different programs and how to apply. It's really great. So in Massachusetts, we have the �𝐻𝐼RC Massachusetts, and these are a variety of programs and services for children and family in mass advocacy. Autism Speaks Massachusetts is information and services for children 0 to 22. And then there is SPED Child and Teen Massachusetts, which is opportunities for children with special needs, including adaptive sports, dance classes, and other social and recreational events for children with disabilities. Now, the Department of Disability Services has 2 waivers. One is the Acquired Brain Injury Residential Habitation Waiver, and Moving Forward Plan Residential Support Waiver. We could go to the next page. So additional benefits that are available out there are SSI, which is Supplemental Security Income, and this is the link. And if anybody wants these printouts of all the links after this, you can just email me or email through how you signed up for the program, and I'll be glad to just send you a copy of all of this. You can Google and get on every state program very easily, though. So SSI pays benefits on financial need. In most states, beneficiaries will be automatically eligible for Medicaid if they get this. It's payable to individuals 65 or older, adults who are disabled or blind, and children who are disabled or blind. They must have limited income and resources to meet the living arrangement requirement. They must be a U.S. citizen or one of certain categories of aliens, and I didn't look into what categories there were. Monthly payment varies up to the maximum benefit rate and may be supplemented by the state after that. The next is SSDI, and this pays benefits to you if you have worked long enough and paid Social Security taxes. So these are disability benefits, and they are payable to blind or disabled workers, their children, their widows, adults disabled since childhood. And the amount is based on Social Security earnings of the insured worker. So there's all kinds of programs out there. There are also Medicaid waiver programs, and these are for people who would otherwise need facility-based care. And there are 3 different waivers in Massachusetts. So the first is the Traumatic Brain Injury Waiver, and this waiver offers extra help in the home if people want to continue to live in the community. The Acquired Brain Injury Non-Residential Waiver these patients have lived in the nursing home or in a long-term care hospital for 90 days and then they want to get home, this program helps them do that. And they don't need 24-hour care and support. They have to not need 24-hour care and support in that program. They have to be able to take care of themselves at that point a little bit. And then moving forward plan community living waiver is when they've been in a nursing home or long-term care facility for 90 days and do not require 24-hour support and live with the family or live in their own homes. And so some of the services that are provided in here are assisted living services, residential habitation services, shared living. These are all types of programs that they have. So shared living with 24-hour support, adult companions, chore services, coordinating behavioral health services. They do day services, family training. They offer home accessibility adaptation, so you can get a grant to make some modifications to your home. They offer homemaker services, and they offer individual support and community habituation. Oh my gosh, I should have practiced that one. Orientation and mobility services, peer support, personal care support, PT, OT, and speech therapy. They can offer pre-vocational services, respite, skilled nursing services, specialized medical equipment, supported employment, transitional assistance, and transportation. So there are also HCBS waivers for adults with intellectual disabilities that are offered by the Department of Developmental Services, and they have to have an intellectual disability that's defined by DDS. They need to meet the level of care needed for an intermediate care facility, be 22 years or older, and need a waiver service monthly. So one of these services they need to meet monthly. These participants live in family homes, adult foster care, or independently and do not need 24-hour care. There are adult support waivers, community living waivers. These need more help than the adult support waiver. And then there's the intensive support waiver. And this requires supervision and support 24 hours a day, 7 days a week, due to behavioral, medical, or physical needs. So as you can see, there are all kinds of programs out there. I'm not going to read the list again of all the services that these specific waivers cover, but basically they are very close to what the other waivers offer. They do also include adult support, adult companion, assistive technology, behavioral support. So these are the kids that, or even the adults who get behavioral therapists that are involved with them. Day programs, they do family training. Oftentimes I see the families I work with, their child gets behavioral support in the school, but then they need to carry that over in the home because they're well behaved in the school because everyone has that positive approach that they take and they follow that. And so oftentimes families have their own means of communication with their children, and it doesn't always have the same positive outcome. So there's all kinds of things that are out there for assistance. So you really have to look into all of that. See how we're doing for time. Oh, okay, I better finish up then. So your final report. So the final part of this report is to outline specific actions or recommendations that you're going to complete for the patient or the family. So basically you're outlining what are the goals that they identified they want resolved or outlined in this report, right? And then you outline that in the report, and then you have another meeting once all the action items are completed and the outcomes have been gathered. And that's really it. These quality of life plans It's a pleasure to get to know families. Sometimes it's in very stressful situations because they're against, the wall trying to solve a problem, but oftentimes it's in advance trying to prepare for something that could possibly happen in the future. And it gives them some peace of mind. So that's it.
All right. Thank you, Cindy, so much for sharing so much information about the essential steps and considerations for developing a quality of life plan. We're going to shift over to our Q&A session. We're short on time, but we do have a few questions in the queue. So I'll start with the first one, and it's what, according to you, needs to be the role of government or different authorities in the effective building of a quality of life plan for children with disabilities, right? Considering both their physical and mental disabilities.
Well, I think that we should take advantage of every resource that's available out there. So I think that they're a big part of the plan, and you really have to explore. The biggest thing is to figure out what piece of this the family is looking for, and really evaluate what kind of services they have now. And oftentimes, the biggest problem is families don't know what they don't know, right? They know what their child needs, but they don't know what's available out there. So I am very comfortable calling these different agencies. There are actually advocacy outreach programs. So you can call one of these advocates and they will let you know all about what is available for that child and the best way to go about it and how to, and help you with the process a little bit. In addition, like the Department of Developmental Services has case managers that work with every patient. So when you don't have, once you get past the advocacy stage and you actually get services in place, you have that resource also. And they've always been really great talking to me to let me know, okay, you want to make sure that this is in place before you do this waiver, because you don't want to nullify, right, something that you've already done, because of something you've already done. You don't want to apply for the wrong thing first, because it could do you out of some other benefit. So learning that about your state is really important, and also whatever's offered federally.
Okay. I think we're going to do one more question. What are some of the biggest stumbling blocks a family would face when needing a plan, such as a quality of life plan?
So I think it's just what I said. Families don't know what is missing from the care of their child. So I think your evaluation of what they have in place and what's still available out there and educating them about that is very, very important. So the biggest stumbling block is families don't know what they want. They don't know what they're looking for. They know one little piece of it, but they haven't really thought of the big picture. So there's a big educational component to all of this. And it's also, because there are a lot of different agencies, it's always hard to figure out where to start, right? And so getting a good grip, a good handle on what they have for services already or what kinds of insurances they have, and then presenting them with a list of all the different services that are available out there and what they have to do to get that is really important and helpful. And it's really important to know, like I said, most people that have contacted me or I have even done life care plans, you have to explore Medicaid coverage before you do a lot of things, because you want to make sure that you do everything in the right format, in the right order, because you don't want to lose another benefit because you didn't know, right? So it's always good to call the different agencies, pick people's brains. Every state is different. And so you just get online and then start and do some research and then start making phone calls. And there's a lot of people that are there to help you and to help the families with this. but you know how to research and you know how to ask the questions. You can't know everything about every single state. So exploring and reaching out to the people who are living in it every day is very important.
All right, thank you. We are just about at time, so I want to thank the participants for joining our third medical legal webinar of 2023. A playback of this webinar will be available within about 48 to 72 hours. Additionally, we do ask that if you were able to watch the webinar live, that you complete the webinar survey. Again, thank you to our speaker, President and Founder of MLCC, Cynthia Borbo. Just a reminder, if you're interested in services provided by Medical and Life Care Consulting, we do provide comprehensive life care planning, medical chart reviews and chronologies, medical cost projections, focused estimates of care, Medicare set-aside allocations, and of course, quality of life planning. We can be reached via email at info@medicalandlifecare.com, or feel free to call us directly at 413-323-9705. Thank you again for your time and participation. Have a great day. Thanks, Cindy.
Thank you.